Hello, welcome everybody in the ESOC television studio. I'm Annemijn and this is Ellis, my co-host. We're from the Netherlands, and yeah, we had a great day today at the ESOC with many trials, and today we have the PIs from the Truth study, Nyika, Kruyt. You're from ELAN substudy, Rohner, and we're waiting for the team from Interact. So for now I'm going to give you the word to my co-chair, Ellis.
Hello everyone. So we'll start with Dr. Kruyt, who I know very well. Could you maybe start with a short summary of your research findings?
Oh yes, sure. Well, the Truth studies investigated whether we should lower actively the blood pressure in patients with blood pressure levels above the guideline for IVT. And the reason behind this was that the guidelines advised to do so, and that was based on the initial trials that investigated the clinical benefit of IVT. However, in these trials, the patients were only allowed if you lowered the blood pressure without the use of IV antihypertensive agents. Whereas in practice, we all use IV antihypertensive agents. And obviously there's also a fear that a swift lowering in the blood pressure could compromise cerebral perfusion. So in the Netherlands we have the unique situation that there are some centers did not adopt the international guidelines but said we are not going to lower the blood pressure actively, but we just wait until it drops spontaneously below the guideline levels, and only then we give IV thrombolysis. So that was the background against which we investigated this in a cluster designed study where all patients were either treated in centers with active blood pressure lowering or in centers with no blood pressure lowering, and then we compared outcomes. And somewhat contrary to our expectations was that the blood pressure lowering group, or the active blood pressure lowering group, was, if anything, doing worse than the patients that were not subjected to active blood pressure lowering.
Very interesting. So did I understand correctly that these patients who did not get active blood pressure lowering had a longer door-to-needle time?
Yes, that's correctly. Not only a longer door-to-needle time, but also much less patients were treated with IVT because they ran out of time and exceeded the time window for IVT. So about half of the patients did not receive IVT in that group, whereas in the group with active blood pressure lowering, it was about 90 to 95%, and with shorter door-to-needle times. So,
and they even did better.
And they even did better, if anything, yes.
Yes. So what's your thought on that? How does that work?
Well, I think, well, first of all, we have to acknowledge that these data are not derived from a randomized trial, but I think for this particular subject, it is the best data available there is. And also, it's very much in line with recent results of other studies, well, in particular the Interact 4, where we see that in the management of acute ischemic stroke, the active lowering of blood pressure is not always such a good idea in the Interact, but I'm sure Greg will tell this later. You can see an even harmful effect as well. So my thought is that we have to go back to the drawing board and rethink of these guidelines, and at least until we find evidence that active blood pressure lowering is beneficial and not harmful, we can start doing so. Another idea would be to challenge the threshold guidelines, which are very arbitrary set in these trials. Obviously, these trials wanted to be very safe and not have the risk on intracerebral hemorrhage, which is associated with a high blood pressure. But maybe we can treat patients despite having a high blood pressure with IVT. That could be a next trial, maybe.
I see.
Yeah, I think we have Professor Anderson now. Can you join us in the TV studio? We are already talking about your trial. Congratulations. Come stand in the middle.
Thank you.
Yeah, and we were, Nyika was already mentioning that it may not be so good, acute blood pressure lowering in acute ischemic stroke. Can you comment on the findings of Interact?
Yes, so thank you. So the INTERACT trial was to test whether very early blood pressure control in an undifferentiated strokes would improve outcome. We purposely targeted patients who had their symptoms within 2 hours of onset, who were hypertensive. And our hypothesis was that if we could get the blood pressure under control very rapidly in this very early patient group, it would reduce bleeding in the brain if they had intracerebral hemorrhage, and that would translate into improved clinical outcome. We thought that for ischemic stroke, it would speed up the use of thrombolysis, because often we've got to wait maybe 15 minutes to get the blood pressure under control with TPA and following the guidelines, and sometimes it's very difficult to get the blood pressure under control, and maybe that would delay the use of TPA. There is some evidence that blood pressure control after TPA reduces bleeding in the brain, and you could make a hypothesis that there may be some neuroprotective effect. But ultimately, we thought that it would be safe in ischemic stroke and offer substantial benefits in intracerebral hemorrhage. It turns out that we have opposing effects. Very clear benefits in those with intracerebral hemorrhage and very clear harms in patients with cerebral ischemia, which in hindsight now makes sense, but at the time was a little surprising to see such effects in such a divergent way. So I agree entirely. The whole role of blood pressure lowering in the context of cerebral ischemia is looking pretty shaky at the moment. The baseline blood pressure levels in our trial were 172 systolic, so that's not far below the target that is recommended in the guidelines. And often there's overshoot and more zealous clinicians who like to get the blood pressure down to 160 or 140. And that doesn't look very good at all in terms of the brain in a very unstable situation with cerebral ischemia. And finally, you have to realise that that 185 pre-thrombolysis, 180 post-thrombolysis was decided by experts around a table when they wanted to ensure that there was standard of care in patients going into the NINS RTPA trial, and unfortunately those protocol criteria in a clinical trial were translated into the regulatory approval to be used for TPA without any randomised evidence. So in the context of the randomised evidence in INTERACT 4 and the observational data from Thrive, I think two independent studies showing the same direction where there has never been reliable data to date are very important. I think we do need to have a serious reconsider over those guideline criteria. But in the context of intracerebral hemorrhage, even with a 20-minute transport time from the scene to hospital with bleeding in the brain, getting the blood pressure under control, you've got a substantial survival and disability benefit. The bleeding by the time they got to the hospital was less in the intervention group. It's remarkable. We didn't show it in the presentation today, but there was less surgical intervention, there was less pneumonia because there was less complications, there was better time in hospital and quality of life. So we have a proven treatment for intracerebral hemorrhage. It's now an implementation issue about how we mobilise our teams better in the hospital and how we can better recognise intracerebral hemorrhage in the field and get the treatment. But you know, in many parts of the world we have patients being transported for 40 minutes to an hour, 2 hours in the ambulance with bleeding in the brain, and now you can just imagine that we are denying these patients an opportunity for benefit.
Yes, I guess it's all about good timing.
Yeah.
And that leads me to Roman. Could you maybe tell us briefly about your study?
Yeah, first of all, thank you for inviting me here. I'm very happy to be here and talk about the ELAN sub-analysis that we performed. And I think I can say that Urs Fischer was here last year at ESOC TV, and he presented the results for the primary ELAN trial. And they investigated like early versus late initiation of anticoagulation in people with ischemic stroke due to atrial fibrillation. And our sub-analysis aimed to investigate whether hemorrhagic transformation modifies the safety and efficacy of early versus late DOAC initiation. So I don't want to bore you with too many numbers or so I try to keep it simple. Our findings were that that in people with ischemic stroke due to atrial fibrillation, we found no evidence for major treatment effect heterogeneity, and also no safety concerns when initiating DOACs early. However, we found a 25% increased risk for a poor functional outcome after 90 days in people with parenchymal hematoma and early DOAC initiation. And this is why we think that early DOAC initiation, that was defined according to the ELAN trial as within 48 hours for minor and moderate strokes and on day 6 to 7 for the major strokes, does not lead to an increased rate of symptomatic intracranial hemorrhages, and appears to be also beneficial in people with hemorrhagic infarctions types 1 and type 2. But in people with parenchymal hematoma, early DOAC initiation may worsen functional outcome.
And so in our clinic in the Netherlands, it's not protocol to make another CT scan. How did you go about this?
Well, that's what we discussed before. The ELAN trial was not designed specifically for this sub-analysis, of course, and that's why the trial lacks a standardized follow-up control. What I told a colleague here, that in Bern we usually perform like a 24-hour follow-up imaging, but it was not the case in all the trial sites. And we realized that, and we also excluded the people that did not have a pre-randomization imaging that was surely after the treatment with IVT or EVT or both.
So what would your ideal situation be?
I'm biased because in Bern we usually perform the follow-up imaging after 24 hours. But I think to answer this question specifically, we would need like a standardized follow-up control with imaging. Yeah.
Yes, I guess. More evidence.
Absolutely.
Right?
Always good.
Okay, I think we've already heard quite some messages that we can take back to our clinics and maybe change our implementation. I think it's already late at the evening. I think we should maybe start to wrap up. We've got a nice ESOC party coming up. I think we should thank the PIs for joining us and chatting to us about the important trials. And you have anything to add, Ellis?
No.
Okay.
Let's go to the party.
Yeah. See you tonight at the party then. Thank you so much.
See you. Yes. Thanks.